thank you, everybody. That always helps our speaker kind of know, what you're dealing with, so that she can filter her comments and incorporate some of what you're up against in what she's saying. So our speaker is Christy Sharpa. She's got a whole lot of letters after her name, and she works also at Mountain Valley Hospice, where I work, and she's our head of palliative care and some other stuff too that I can't remember. So Christy, tell us a little bit about yourself and then just take it away.
Sure. Well, I'm a longtime nurse, and my background was in critical care and oncology, and I had an affinity for hospice work. So several years into my career as a nurse, I went to work for a hospice. I'm from Buffalo, New York, and I went to work for a hospice there. And within a couple of weeks, I realized I was doing my life work, that was what I was put here to do. So I worked for them for a few years very successfully, and they pulled me aside and sat me down one day and said, would you be interested in completing your master's? If you will do the degree, we'll pay for it, help you be a nurse practitioner, because we would really love you to do a higher level of care for us. So I took that opportunity, completed the degree, worked with them for a few years, and developed what was new at the time, their palliative medicine service in a hospital back in Buffalo. And I was there doing that for 5 years. And then my family realized it was time we've been talking about moving to North Carolina for quite some time. And I have family here in Pilot Mountain, so we wanted to come be with them. So we moved here. And the first thing I did was look up Mountain Valley Hospice and Palliative Care. I was familiar with it because they have an office in Pilot Mountain, and since my family is here, I had driven past it for years, and I had always said, I'm going to work there someday, I just know it. So it was really fun and exciting to interview with them, and at the time, they needed a director of palliative care. So what they had done was, for years, I wasn't around for this, but I want to say at least 7 years, they had been accepting palliative care patients. And they'd done a great job with them. It's just that there wasn't a lot of structure. It wasn't like an actually structured kind of program. So they decided they wanted to have a director to just kind of offer some leadership and structure and kind of get a handle on what their services were going to be. So when I started 2 years ago, I started as the director of palliative care. We hired a bunch of nurse practitioners, and we're kind of a nurse practitioner-driven, community-based palliative care program. And I use that terminology carefully, because I think when you say program, people think of a traditional program that offers aids and skilled nursing and that kind of thing. And I have to use those words carefully. Palliative care is a medical practice, and it's a specialty that came about, I think, out of a dire need, because in medical care, we have a lot of wonderful doctors out there, and they're great at treating the disease, but they often forget about the symptoms that come with the disease, or the symptoms that come with the treatment that they're offering, like is true often in chemotherapy. So palliative care kind of came out of a necessity, really, of a hole within medical care. And we've all been given the opportunity to create palliative care at each place that we do it in our own way. So it's not governed in any way like hospice, for example, which is Medicare paid for and driven, and there's governance. And while you can go to different hospices all throughout America, you might find some minor changes, but there's major similarities because it is a defined program by Medicare. Palliative medicine is a medical specialty. So every palliative medicine practice can decide how they want to structure, the kind of patient they're going to see, how they're going to run their practice. So it can vary very widely. But what we wanted to do is just kind of create a template, if you will, an overview, get some very well-trained practitioners in who are good at really answering to people holistically, not just not just seeing a person on paper or on a chart, a name on a chart, but really looking at the whole person. So for that reason, we have done most of our palliative care services in people's homes. We're equipped that people could come and see us in one of our offices. And we're happy to do that when it's convenient for people. But what we're finding with our patient population is most folks are worn out from running out to different doctors' offices and having multiple specialists. It's very hard to get their loved one in and out of the car, especially if it's cold and icy, or right now when it's 95 degrees. It's so much better when we can come to them. So in our palliative program, we are very much home-based, and we come to the patient. And we are offering a medical specialty just like any other specialist. So just like a kidney doctor or a lung doctor or any other specialist, we come in as a specialist who focuses on symptom burden, discomforts, and how can we minimize those symptoms, such as pain, shortness of breath, anxiety, difficulty sleeping, constipation, agitation is a real common one. A few of you mentioned having loved ones with dementia and Parkinson's. And we see a lot of sleep disturbance, late day agitation, nighttime agitation, behaviors, and that we often help with that kind of thing. And housed within all of those symptoms and these different diseases that we see out there is always the need to frame, well, what are the patient and the family's goals for care? Because some people feel very aggressive about a treatment regimen, and some people feel more comfort focused. Some of our patients are younger, and the goal is to really, lengthen life at any cost. Some folks are older and they feel like, I really want to focus more on my comfort as opposed to longevity. So we treat patients of any age. We do have a physician that works with us who specializes in pediatric palliative care, but the rest of us focus on adult 18 and older. And we really serve patients through every spectrum, the whole age spectrum. Our patients might have COPD, heart disease, any type of pulmonary diseases, cancers, certainly, dementia, Parkinson's. Those are probably our most common illnesses that we treat, but that's certainly not an exhaustive list. And we are really focused on being a good partner for the patient with the rest of their medical team. So we're not a primary care service. We don't come in and do the whole, treat every disease, because we're consultants and we want to be honoring to all the other doctors and not step on their toes, and and honor the fact that they're part of the treatment team too. So when we get a referral, we'll often ask, what is it you're looking for? What is the disease process that you're concerned about, the symptom you're concerned about? And are you looking also for some goals of care discussion, maybe some help with advanced directive? Maybe do I want to consider a feeding tube or not? Am I ready for a DNR, or do I think it's too soon? Having those really complex discussions, we are really good at shepherding people through those. So those are the main categories of what we do. But we were very, very careful to also cooperate and communicate with the patient's other doctors, because we don't want to step on toes. So for example, if we have a patient who comes to us who's looking for support with their COPD and they're just having a lot of shortness of breath, we can come in and we can help with that. And then we're going to be sending a note from our visit to that patient's pulmonologist so that they know who we are and what our recommendations are, and so that they're aware that we're part of the team. And then if about a week later that patient's like, geez, I'm feeling more short of breath today than usual, I'm going to call Mountain Valley and see if they maybe can make another recommendation. Maybe I need more medicine, or we got to change something. They're welcome to do that, and that's exactly why we're there. We want to help people stay out of the hospital and help them navigate their illness and their symptoms. But if they say, well, I'm calling because I was in the backyard and I fell and I kind of think I hurt my ankle and it's swelling, that kind of thing really still would have to go to their primary doctor or maybe to urgent care. So we really want to be clear that we're following that patient for a particular disease process and for the issues that surround that, and so that we're not, you know, misguiding any medical treatment or that kind of thing. We do bill. Our service is billable, and that's a confusing point for folks sometimes because they feel like hospice is free, and palliative care should be too, and we sure wish that it could be. But we do have to, we're obliged by law, actually, to bill the insurance for our visits as a specialist. And then there is a, whatever copay comes with that particular person's insurance, that is what the patient has to pay. They don't pay it to us, but there is a copay fee that comes with our visits. But we really do a good job of trying to stay on top of our patients' needs, try to see them monthly. Some patients like to be seen a little less often. Some patients come to us very sick, and we have to see them a bit more often to just get them on track. So what we do is we have a screening process so that we can be sure to see patients in an appropriate manner. So when the referral comes into us, we gather all their medical information that we can get, and we screen them for their needs. How sick are they? What situation are they in? How quickly do we have to get out? Oftentimes we get referrals for folks who probably really should be hospice, but they've been seen by hospice already and they just aren't ready. So that we are kind of like the, well, if you're not ready for hospice, how about palliative care? So the folks will be sent our way, and their needs are sometimes beyond what we can do in our program, but by going out as quickly as we can, having those really complex conversations, taking a look at the medical picture, taking a look at the medications, we can sometimes get people more comfortable either with their symptoms and their disease, or maybe also with decision making. It may be that once they just had someone sit down with them for an hour or two and just talk through the illness and what's been going on, they start to become maybe more comfortable with considering some hospice care. And we're really adept at explaining the difference between the two, because that's a really confusing point for a lot of people. And it is confusing. I mean, there's no doubt that there's a lot of crossover there. What's nice about palliative care being a medical practice outside of any type of program is there's no limitations. So a loved one of yours or you could have palliative care, and you do not have to stop any kind of treatment. You don't have to say no to the chemo. You don't have to stop a blood transfusion. You don't have to give up your favorite expensive medication, because we are not a program. So you're not signing on and subscribing to anything. When we come see you, it's just as if you went to a medical specialist of any kind. So you're not giving anything up, which is really good. Another thing I wanted to share that I thought was so important, because caregivers, they need all the help they can get. So if you've got community resources in place, if you've got home health or different community resources coming in to offer aid care or nursing support or volunteer sitters or what have you, sometimes there's certain programs that come in and one cannot coexist with the other because they're tapping into the same insurance or what have you. But we are not a program. We're a medical specialist. So we can coexist with home care and all of those different programs. Oftentimes we'll come to the home to see a patient, and the patient's nurse, home care nurse from any agency X will be there, and they'll get very nervous because they'll say, oh goodness, if you're here, we have to back out and we have to discharge this person. And we're always really quick to explain, no. What's happening right now is that this person is coming to a doctor appointment with a specialist. We're just kind enough to come to their home and make it a little bit easier for them instead of having them come out to a doctor's office. But what they're having is a doctor visit, and that does not preclude anything else. So they can keep their home, all their home services in place. None of that has to stop because of us. And I can't stress that enough, because we've had that happen as recently as this week. 2 different home care agencies pulled out on patients who were being seen by us just because we're in the picture, because they fail to understand what we offer. And I think the confusion comes in because we're going into the home, so they think of us as home care, and that's not what we do. Um, so that's a really important point. And if not only for you to understand, but for you to share with your family and fellow caregivers, I think any opportunity we can all take the ownership of just educating everyone, especially folks who are aging and moving through different disease processes. You know, palliative care is opens doors, it does not close doors. So that's a good thing to know. Um, I'll just brag on Mountain Valley for a minute because I know that there's others on the call here who do awesome palliative services also. I know Angela offers a wonderful service. What we do is we have had folks come to us who don't have insurance or just say, I have insurance, but I cannot afford the copay. I can't do it. So that's not a problem. We will not turn away care from anybody because of their inability to pay. So we will provide care to everybody who comes our way. For folks who say, I've got insurance, I'm just really strapped money-wise, we just have a one-page, very simple application. And by virtue of that having been filled out, we can show that we've done our due diligence, which is by law, we have to do. And then that way we can see without, we still have to bill, we just don't have to collect the bill. So basically it makes us able to provide the services even for those who cannot afford it. So I feel really proud as a provider and a Christian to be able to say that, that we do not turn anybody away because of inability to pay. I think I mentioned we're primarily a nurse practitioner driven program. There are 6 nurse practitioners, but we do have governance from physicians. So Dr. Dan Ray, they are meeting with us regularly. We go through all of our patients. We have something called interdisciplinary group where we sit down with the doctors, social worker, chaplain, and we talk through and we present our patients, what we're doing for them, what their challenges are, what we feel our treatment plan should be, and we just have governance to make sure everything's on the up and up and that a doctor has been involved in the process. So we run a very safe practice. And we're really blessed to have the overlay of some social work support because some of our patients have social work needs, and then chaplaincy. I've met with patients where, you know, I find out that their medicine is really okay for them. What they're really hungering for is prayer or some spiritual support. And then I can have a chaplain come in. So instead of prescribing a certain pill, I might prescribe some time with the chaplain. So there's avenues to help patients that aren't just about writing a prescription. And that's good to know too, that we are, you know, multidisciplinary and we offer that level of support. We do advanced directive discussions. That's probably one of the most common things we do. So we can complete the DNR form. We can complete the MOST form, which is that North Carolina pink form that kind of goes through all the main things in terms of what wishes might be, antibiotics, IV fluids, feeding tube, all the heavy hitters of decision making are on that pink form. We are able to do those and sign those. One of the sticky challenges can sometimes be appointing a healthcare proxy, and we're great at having the discussion, at explaining what a healthcare proxy is, how you want to choose one very wisely. But North Carolina does not make it easy. They currently want you to have 2 witnesses who are not relatives and who are not medical at all to witness the form, and then it has to be notarized. So you can imagine what it's like trying to coordinate that with someone who is already struggling with their sick loved one. But there is legislation active right now in North Carolina to make that process easier. There's a waiver right now too to try to make that process easier because of COVID. However, the waiver is, I don't know that it's necessarily made things easier, if I can be really open and honest with you, but they're trying, and I give them credit for trying, and I'm hopeful that in the months or year to come, we're going to see North Carolina make some changes, and appointing a healthcare proxy will be as easy as a visit with your practitioner, and you know, perhaps any witness. Maybe, you know, you don't have to find the neighbor down the street, which maybe it could be they could lighten up on the witness thing a little bit. So that's the kind of thing we help with too. We do have a person on the Mountain Valley staff, one or two people actually, who are notary publics. So when we really need to, when there's difficulty with getting your loved one out to the bank where there's a notary or to the lawyer, we're able to bring one or two of those people in. We do, of course, have to work on the calendar and set up a date and everything that works for everybody, but we coordinate and try to get a time when there could be witnesses and a notary and hopefully get that done. Many times though, folks, it's not even about signing on the dotted line. They're not necessarily ready to sign any form. They just want to have some discussion and they don't want to feel pressured. They just want to feel like they can talk to someone they can trust about what should I expect with my disease process based on where I am now and how most people process through this disease. What would you say, you know, my time looks like, and what would you recommend in terms of feeding tube or no feeding tube? What outcomes have you seen in the past? What works, what doesn't work? They just a lot of times want to bend your ear and just talk through what they're going through, and just have someone to listen and to guide them a little bit based on their experience. So that's also a big part of what we do. When we screen our patients, we're being very certain we can see them and serve them. And the reason I clarify that is because in this day of chronic pain and the opioid epidemic, we have gotten, you know, referrals for folks who what they're really looking for is pain management for more of a chronic pain, like maybe fibromyalgia, or maybe they had a car accident a long time ago and they're having chronic spinal pain or something like that. That's not palliative care. That's actually pain management, which is a separate specialty. And we would be so careful medically that people that call on us for help, that we serve them well and that we're appropriate in our medical care. So if we know it's not appropriate to be seeing a certain patient, we'll be very honest with them, we'll explain why, and then we have a grid that lists all of the pain clinics in the region that we serve, which is about 18 counties between Virginia and North Carolina, and we can at least give people that and let them have some references to pain clinics. So we do screen to make sure that folks have an illness and an associated symptom or a need for discussion. And then that way we're not going out and under any false pretenses. And we certainly do not want to collect a copay for a service that was not helpful to folks. So we try to be very, very careful that part of our screening process is to call the patient or their family and say, this is who we are, this is what we do. We just want to be sure this is what you were looking for. We then have them speak to our billing person so we can give them some sense of what their copay will be ahead of time so that there's no surprises and so that people can be comfortable and prepared. So we have a nice process put into place. For patients who get referred to us who really should be hospice and who are really struggling with their cancer pain or what have you, we try to get out as quickly as we can. We can sometimes even get out the next day. We will do everything in our power to do that. We do schedule like a doctor's office. So we're kind of, you know, we do book up sometimes, but we do fancy footwork and we try our best to get people in quickly for emergency reasons. But in general, when folks are more stable, we'll try to get them in the next week or two when they call. And we've even had folks call and say, you know, well, I just wanted to hear about you and get on your calendar, but I'm not quite ready yet. Can you wait till next month? And that's fine too. There's no pressure. There's no rush. We're here to serve, and we want it to be helpful to you, so we don't want anyone to ever feel pressured. You could even just call us if you just wanted to one-on-one learn a little bit more about our services, but you weren't quite sure you wanted them. That's okay. There's no pressure. We get calls all day long for folks who just are kind of feeling things out. You know, my mom's at home. She has dementia. I'm caring for her. She's making some changes. I'm having trouble gauging what her needs are and what to expect. And we just kind of talk it through and figure out, you know, what the best service, if any, would be. So we're there for you, and we're there for these phone calls to kind of weed this stuff through. I think I hit most of the highlights of what our program is, and I know that we have another guest on Angela who also offers palliative care services. And I don't want to be a hog, Angela. Would you like to share anything or add anything about your services?
No, I think you've done an excellent job, and I would say that Trellis and Mountain Valley kind of parallels each other. We
Okay.
do some of the very same things. So just as you're saying that hospices are pretty much, they have this great big thing that's in common. I think some of our palliative specialties do also.
That's great. It's good to know we're kind of working very similarly. And I
Yeah.
know in the community, my church is actually in Winston-Salem. And so I'm, well, when life was normal, we were at church every Sunday anyway. I was in Winston on Sundays, and so I heard a lot about Trellis and the palliative care services, and I've just always heard remarkable things. So I just think that you guys have done a wonderful job.
And I will say that we do some virtual visits, just like you. We have a clinic on our campus. However, we go out to the home to make those visits because, again, it's sometimes difficult to get people to come in, or they can't come in. So we are doing home visits. However, with the whole COVID thing, there are times that we do have to do visits by phone. So we're doing virtual visits also.
That's a great point. Thank you for bringing that up. You know, we are in a season right now where if it's more comfortable for folks, we are offering the virtual visit. For a first-time new patient, we really feel more comfortable physically seeing the patient. We just feel it's safe practice to listen to the lungs, listen to the heart, and have that physical assessment. But we are wearing full PPE and being very careful. But for follow-up visits, for folks who just feel like, you know what, I really want some palliative care, but I am just not comfortable with anyone in my home right now, we understand, and we are offering telehealth visits that are a lot like this, that, you know, kind of like a FaceTime thing, and we're able to still serve. Interestingly, we jumped on the telehealth thing when COVID started, thinking, well, this will be the be all end all because no one's going to want us around with COVID. What we have found is we do very little telehealth, and most patients are saying, I am lonely, I am hungry for human connection, and if you will wear your PPE and wash your hands and be very careful, I would actually prefer you come over. So we're mostly still doing home visits. But Angela, I want to thank you for reminding me of that, because that is an important thing in this day of COVID, to let people know that we are available in all different ways. It sure is interesting times, I'll tell you.
So this is Allison Brown. I have a question. So if I'm in the hospital, say at Wake Forest Baptist in Winston, and the palliative team there is coming to see me, how is that different than what you hospices offer?
Right. It's pretty much the same thing, except they are serving an acute population in the hospital. So what we'll often do, and this happens very regularly, is the palliative care team will see the patient. They'll be referred by the doctors in the hospital because there's an advanced illness or the need for complex discussion, or both. And they will, they'll do their consult, they'll provide treatment, they'll be part of the treatment team. They might even help the patient and family do a DNR or something like that. But then they realize, well, this patient's going to do well enough to discharge home. We've done all this work getting them settled in with palliative care. Now, who do we send them out to? Well, that's when they call us. And they will often call us directly and say, I've got a gentleman here, he's going to discharge home whenever, Monday, and we really feel like to continue palliative in the community would be a great thing. Will you pick him up? So there is a lot of hand-in-hand coordination there. But you know, community palliative care tends to start with folks who maybe are a bit more stable and maybe a bit further upstream in their illness. Having done palliative medicine in the hospital for 5 years, I will tell you it's much more acute, urgent. Something has happened to someone, they are now very sick, and you're being called in at a time of very high stress, lots of illness, lots of hands in the pot, and you're trying to kind of be the peacemaker, the organizer, the one who's not forgetting to ask them about their pain and provide the pain medicine. And oftentimes, I'm going to say 99% of the time, the need is for goals of care discussion, because these folks are so sick and they're a full code, and there's a need for the hospital to understand, you know, what are the goals and wishes? What are we doing or not doing here? So that's a big piece.
Christy, explain what full code means, please.
Okay.
What is a full code?
A full code is somebody who wants every possible medical intervention done, no matter what, to prolong their life.
And that's the default if I'm in the hospital and I don't have a DNR or a living will or any of the advanced directives. Full code is the default.
It is. And even if you have those directives, if they aren't available, if they're smudged, if they're ripped, if someone doesn't feel that they were done properly, they will default to full code.
Okay.
So yeah, now there are different layers to decision making. So do not resuscitate is, you know, it's not saying I don't want treatment. It's not saying I don't want medical care. It's saying if my heart and breathing stop, I want to pass peacefully. I want to focus on comfort, pass naturally, pass peacefully. I don't want a breathing tube put into my lungs to help me breathe. And I don't want someone to push on my chest and try to make my heart restart again. So that's what a DNR is. And we have many folks that come to a place on their journey where they say, well, I'm a little bit full of signing a DNR because I still want chemo, and what if I need a blood transfusion? And they just don't understand that you still get all of that. That doesn't stop any of that treatment. A DNR is strictly your heart and breathing, and if they stop, it tells medical people to not try to restart them. They could still give you medicine if they felt you were struggling to comfort you and so that you wouldn't suffer. But it just tells them that you would not want to be put on life support, essentially. But then that most form that I mentioned, the pink form, that goes into much more complex things. Do I still want IV antibiotics or not? Do I want a feeding tube or not? There's different kinds of feeding tubes, but I want to try a temporary one down my nose, but not have one surgically put in my belly. So it can be complex. And that's where having some guidance from Angela's team and my team, you know, would really be helpful.
So we have a question.
I see that. Can you get a copy of a DNR? So yes, you can, but the DNR really, ideally, you want to have the original with the patient whenever possible. It is in North Carolina a bright yellow form. They color them for a reason. And the patient should always have the original. So you could, if you decide, so I see Vince's face here. If Vince decides, I am ready for a DNR, you could have one done with your doctor. He would keep a copy in his file. You, Vince, would get the original. So the original should be with the patient, but copies could be given for information purposes to your different doctors, maybe to your daughter or your son, but you'd want to keep the original with you. And Allison, you're on mute. Can you have palliative care?
Thank you. It's the DNR is a document that has to be signed by a doctor. It's not a document that you sign or that you can implement or execute. It has to be signed by a doctor.
Yeah, that's a really good point. DNR is signed by a doctor or a nurse practitioner, certainly with your permission as the patient. But the difference with a most form is that the provider, whether it's a doctor or a nurse practitioner, and the patient sign the most form. So
I can send everybody samples of what these look like if you haven't ever seen them and kind of want to look at them. I love the most form. I tried to get one done. Y'all remember Terry Shivo, the young woman from Florida many years ago? We talked about her before in our classes when we've done our advanced directives clinic.
Yeah.
And I went to my doctor to get a most form, and he said, "You're not old enough for one of these." And I said, "But now wait a minute, you know." But they are more prevalent in the assisted living and skilled care settings. unless you're very, very sick and you might have one at home. And
So
stuff.
Allison, what you were probably searching for more as a younger, healthy woman is a living will, a way to tell people this is what I do and don't want. And you can absolutely do that through that avenue. The most is really, when we want to look at doing a most, we, as medical people, we look and we say, do we think this person, would it shock us if this person passed away in the next year or so? And if our answer is no, then it's time for the most form. But if you're upstream from that, I'm not going to say the most form is wrong, but it's more that you would do your living will. Yeah.
Right. Thank you. So yeah, there's that next question for you, Christy. Can you see it?
Yep. So can you have palliative care and CAP-DA at the same time? What is CAP-DA? I'm not sure what the question.
All right, CAP-DA is a program from Medicare that is funding that allows for a family member to be paid for providing care in the case of an adult.
Yes, so you can, because again, that person that has CAP-DA, if they get a dental abscess, they go see a dentist. If they get pneumonia, they might go see a lung doctor. If they have renal failure, they might go see a kidney doctor. We're just another specialist. So there's no limitation having us involved with any of those other programs, the CAP or any other. We don't get in any of the way of the care. And Millie is saying that she's had a living will since she was 38. That's wonderful, Millie. I have two. I actually ended up on life support when I was 25 years old, and I survived, obviously. But right after that, I learned the importance of telling your loved ones what your wishes are, because it can happen to anybody. And then I went right to my lawyer and got myself all taken care of with documenting my goals and wishes. My daughter, on her 18th birthday, she's now 22, on her 18th birthday, I sat at the kitchen table with her with a healthcare proxy form and talked about her wishes and had her appoint me as her healthcare agent. So I take it very seriously. I practice what I preach. So that's awesome, Millie. And I really think everyone should do that. And maybe COVID, maybe this year, 2020, has taught us, if nothing else, that anything is possible and anything can happen to anybody. So, okay, so Millie's mother passed very young, and she's recommends it to everyone. I think if you walk the shoes, you learn the lesson. And Millie, the fact that you want to teach other people and save people a lot of heartache by thinking now early about what goals and wishes are. There is a website, and it's called The Conversation Project. And on that, there's a section for providers, and there's a section for just folks who want to learn about advanced directives. And they basically walk through how to have conversations. So they'll give advice for, how do I open up this discussion with my son without scaring them, or my wife without scaring her, or whatever the case may be? Because some people are like, I just don't know where to start. I wouldn't even know what to say. They even recommend to use Thanksgiving dinner or a time when the whole family gets together each year. Take time out during that to just touch base with each other. Have your goals and wishes changed? What would you want? Heaven forbid you can't speak and you're in trouble, and the doctors want to know what you'd want. What would it be? I think it's hard, but it's really important to have that discussion. Do we have any other questions?
All right, y'all, don't be shy.
So something that I can offer. It's not a question.
Okay.
But when we're meeting virtually, we're not able to share printed flyers and brochures like we have been in the past. And I have Mountain Valley's brochures and literature, as well as Trellis's brochures and literature. And if there's interest, Allison, perhaps you can attach those to a follow-up email.
We can certainly do that. Would y'all like, caregivers, would y'all like to receive some printed materials about what we've talked about today? I see some heads nodding. Okay. All right, I'll send
Mr.
that out.
Harris is giving us a thumbs up.
Yes, thank you.
Oh, you can see that. Good.
Yes.
Yeah, we can see you well. All right, now y'all don't be shy. You always have a lot of questions after we have a topic like this.
Is
We
it possible
also-
to get a list from you for the North Carolina pain clinics? Yes, we made like an Excel spreadsheet, and if it's okay with Allison Brown, I will send it to her, and then she can send it to all of you. That's no problem at all. And one thing on the topic of the pain clinics, you know, there's a lot of, I don't know, preconceived notions about pain clinics and ideas people have about them. But I want to say this, as someone that practices medicine, pain management is a specialty, and it's not always about a pill. They do all kinds of nerve blocks and interventions, and you know, to treat pain. So you're really selling yourself short if you don't go to a pain clinic when you've been told to go to one, because they offer so much, and there's people there just like you who are having pain, and not everybody there is you know, addicted to opioids or has other issues. We're all people. We've all got our stuff, and some people's stuff is chronic pain. And so just don't be afraid to go to pain clinics, and understand that they offer all kinds of things, from exercise and physical therapy to nerve blocks to shots to implanted pumps to you name it. And see, and we don't do that in palliative care, which is why I'm so careful to be sure that I send people the right way. I mean, I could be irresponsible and just give everyone morphine, but we're very careful, and we really look at their medical, and we do the right thing by them. So yes, I will get that to Allison. Yeah, lots of opioid issues. I hear you, and you got to be careful. And the pain clinics will be very careful in terms of monitoring you. They will survey you ahead of time for your risk toward becoming addicted to an opioid. There's a certain way we can calculate risk, and then if they decide opioids are the right thing to do, they would use the smallest, weakest dose possible for the kind of pain you're having. And when used appropriately, they're wonderful things, opioids, but you gotta use them appropriately. And you have to take them with a stool softener. Please, please, please. That's the nurse in me. I don't want a bunch of constipated people out there. So please take your bowel regimen with your pain medicine.
Yes, ma'am. I get that. I have y'all know I'm kind of a history person, and I like context. And it's my understanding that palliative care really kind of came into its own as recently as the last 10 years, maybe 10 or 15 years. So it's mostly attached to hospitals. How did it get attached so closely to hospice? I mean, it's clearly a natural progression, but do you know about that aspect of it, Christy? Kind of how did hospices come to embrace it?
Yeah, I mean, I'm sure there's some story out there that's far more articulate and well-spoken, telling the story of palliative care, but I think it came out of necessity and it attached to hospice, because what does hospice do when they treat a patient? They look at every symptom, they look at them holistically, they care for them as a social being, as a spiritual being, as a physical being, as a mental being. And so and so does palliative care. So it just stands to reason that and then two, in treating hospice patients with such a beautiful, broad, holistic approach, where you've looked at the whole of the person, and you've asked them, are you sleeping at night? Are you eating well? Are you having any trouble swallowing? You know, all those things that a lot of people don't think to answer, because they're, you know, these poor doctors, they get 10 minutes with the patient anymore. They're so rushed. It's not their fault. It's just the system. So we take the time. We're so thorough. And we've all said, in working in hospice, wouldn't it be so wonderful to be this holistic and offer this type of medical care, but not wait till the 11th hour, but do it a little bit further up in the illness. And if we did, would people live better? Would they live longer? And so in asking ourselves that and doing that, we started to look at ways to move it upstream. And that's really where palliative care was born. all hospice care is palliative. Palliative is a term that we've used in hospice forever, but not all palliative care is hospice, because clearly there's a lot of people that get palliative care that they're nowhere near getting hospice. So palliate is just a word that means to comfort. And you know, you can be nowhere near end of life, but have a real serious thing going on where you just need it comforted. You need the situation comforted. And many of our Parkinson's and dementia patients, they've got, you know, 5, 10, 20 years even that they're still going to live. But that doesn't change the fact that they've got, you know, challenges today that are very real and very, you know, it takes away so much from people when they're suffering. If they could just sleep at night and have their symptoms managed, they would do so much better. I don't want to make it sound like a magic wand. I don't want to make it sound easy, because oftentimes with dementia, managing the agitation is very difficult, even when you have palliative care help. We don't have a magic pill and a magic wand, but we're just a layer of support to maybe make it a little bit easier. And hopefully, every once in a while, we nail it and we get someone who, you know, their agitation is gone, they're sleeping at night, they start eating better, and those are the times that you celebrate. So at the very minimum, we're a layer of support. I'm looking at I had jotted down some notes for myself. I'm just making sure I covered everything. I think I did.
I think you did too.
We go anywhere. We go to nursing homes, skilled nursing, ALF, you know, private homes. And for people who would rather not have someone in their home, we'll find a way to see you in one of our offices. In the next several weeks, we're going to be opening an office in the Winston-Salem area on Stratford Road. We're not entirely sure what that's going to look like yet. We're formulating our plan, but we have enough need to be down that way, and it's we just need to have a home base. So 99% of people want to be seen at home, but for the few that just prefer to not be at home and want to go somewhere, we will be able to accommodate that. There's no age requirement on palliative care. It's just that at least for our program, you have to have an advanced serious illness and an associated symptom that we can treat, or the need for, you know, advanced directive goals of care discussion relative to that illness. So for the more longer lingering chronic illnesses like fibromyalgia or things like that, that really doesn't fall into palliative care so much, at least not the way we do our program. It's more actual defined illnesses like COPD, all the different heart diseases, you know, heart failure, there's many different kinds, pulmonary hypertension, pulmonary fibrosis, all the different dementias, all the different neuromuscular diseases, certainly all the cancers.
I have a question.
Yes.
I'm a caregiver for my brother, Ronnie. He's soon to be 65. I've had him 15 years almost. He has Down syndrome, and he's in his 3rd year now of Alzheimer's. He's doing well health-wise. Mentally, he's declining fairly quickly at this point, mentally. We're having trouble right now with him just constantly hollering out, crying, whining, that kind of thing. And I have an appointment with the neurologist, but we are trying to keep him from, of course, going to a home. That's just not an outlook for us at this point. So we're trying to find a medication that is right for him. He was a sundowner, but now it's when his feet hit the floor all the way, he doesn't sleep at night. So we are strained completely 24 hours at this point. My husband's on furlough, so luckily we are rotating shifts with him right now.
Right.
But, so I don't know whether that is something palliative care could offer, or whether I need to stick with going to the neurologist and trying more medicines. Like we've done Seroquel, we've had Xanax, and it's like one medicine might work one day and not the next. And so I don't really know what the next step would be.
Yeah, that's a good, we do have many patients like this is your brother-in-law?
No, my brother.
Your brother. We do have many patients like your brother, 4 or 5 right now off the top of my head. Same kind of diagnosis, same story that you're telling me. And we've been fairly successful with them. Some of the challenges when we treat the agitation, sometimes it's hard to not go too far the other way, and then they become maybe sleepier than you'd want them to be, or more somnolent than you want them to be. Obviously, the idea is to have them be meaningfully wakeful and engaging in life and not be agitated. But finding that beautiful middle space is very challenging. I think the benefit to palliative would just be the convenience of us coming to the home, which is something the neurologist probably wouldn't do. I don't think it's a bad idea, though, to have him seen by a neurologist either, just to get as many, as different opinions and different ideas. He's young. He presumably has a long time to live. And so getting a neurologist involved, if it was me, I would. But we would be willing to work with the neurologist as a team and see what we could figure out. But I got to be honest with you, the medicines you named are the same ones that tend to be our go-to. Certainly Seroquel, and there's others, but Seroquel and all the drugs in that family are what we would commonly use. Xanax and the drugs in that family we would commonly use. So I don't want to oversell us as if we have a magic, pill, but we could at least walk the journey with you. And heaven forbid he really, gets much, much worse. Just help you navigate that in terms of what the goals and wishes are and how best to honor him.
Okay, thank you.
Sure, yeah. And Bonnie, if you do happen to call for a referral, whoever you speak to, just let them know that you met me during this talk. And
Okay.
That'll just kind of trigger that, who he is.
Okay, thank you.
Mm-hmm.
We have a neurologist. He's been seeing one,
Good.
regularly or whatever. But with the COVID thing, I've had to cancel an appointment, and then it's gotten pushed out so far that it's been hard to get any help anywhere. So
It is. It's difficult. We are actively doing appointments now, COVID or no COVID. So feel free to give us a call.
okay, thank you.
Sure. Well, I appreciate everyone letting me come on today.
Thank you, Christy.
Yeah, thank
Let's
you.
give Christy a big hand.
Yay. Thank you, everybody. Thank you for listening. And Angela,
Right.
thank you for everything you do over at Trellis. We appreciate it.
Yes, we do. Well, if nobody else has any further questions, I guess we will conclude this session of Caregiver Academy. Thank you for everyone that joined us today. Thank you, Christy, Angela, for adding. Shannon has a question.
I was just going to say that during the presentation, we muted everybody for some of the background noise, but if somebody does not know how to unmute your phone to ask a question, raise your hand real quick so we didn't miss you.
All right, I don't see any raised hands. All right, well, I'm not sure what our topic is going to be for August. I can't remember, or we're not sure yet. But you get my emails, don't you? And we will send those out, and we'll send out this information that you've requested, a list of the pain clinics and palliative care information on Trellis and Mountain Valley. And I thank you. God bless you. Godspeed. Y'all call us, lean on us if you need us. That's why the steering team is here. We're here for you. We're here to support you. Okay?
Thanks, everybody.
Thank you. Bye-bye.
Thank you.
Bye-bye.